Welcome to this audio recording. This is a clinical approach, a hypothetical case discussion with questions that test the key concepts for a particular disease presentation. Today I'll discuss a 17-year-old with nausea and vomiting. A 17-year-old girl with a history of type I diabetes is brought to the emergency department with nausea, vomiting, lethargy, and dehydration. Her mother reports that she stopped taking her insulin a day before the presentation. She is a thin woman in mild respiratory distress. Her respiratory rate is 28 breaths per minute, her blood pressure is 80/40, heart rate is 112 beats per minute, and her temperature is at 7.2 degrees Celsius. There are normal heart sounds, the lungs are clear, the abdomen is soft, and there is no organomegaly. She is responsive and oriented to time, place, and person, but somnolent and weak. Her mucous membranes are dry. These are her lab results. Her serum sodium is 126, potassium is 4.3, magnesium is 1.2, blood urea nitrogen is 76 mg per deciliter, creatinine is 2.2 mg per deciliter, bicarbonate of 10, chloride of 88, and a serum glucose of 40 millimoles per liter. Question 1. What is the most likely diagnosis? The most likely diagnosis is diabetic ketoacidosis. Question 2. Apart from nausea, vomiting, lethargy, and dehydration, what other symptoms are associated with diabetic ketoacidosis? Other symptoms associated with diabetic ketoacidosis include abdominal pain, polyuria, and polydipsia. Question 3. What would be your top 3 differentials if this girl presented with acute onset abdominal pain, nausea, and vomiting? My top 3 differentials would be appendicitis, ectopic pregnancy, and diabetic ketoacidosis. Acute pancreatitis could also be a differential. Question 4. What are the endocrine emergencies associated with acute abdominal pain? Another endocrine emergency associated with acute abdominal pain is an Addisonian crisis. Abdominal pain in both DKA and Addisonian crisis may be associated with mesenteric ischemia. Question 5. What are the precipitating factors for developing DKA? Anything that leads to an increased requirement of insulin can lead to DKA in patients with type I diabetes. Some of these include non-compliance, infections, commonly urinary tract infection and pneumonia, treatment failure, surgery, trauma, burns, and drugs such as glucocorticoids. Question 6. What is the pathogenesis of DKA? DKA is commonly seen in type I diabetes, an autoimmune disease where the patient has complete or near total insulin deficiency. 70 to 80% of beta cells are destroyed in patients with type I diabetes, and insulin is required for survival. Skipping a single day of insulin can have devastating consequences. This insulin deficiency and increased counter-regulatory hormones causes inhibition of glycolysis and increased gluconeogenesis and glycolysis. The ultimate result is hyperglycemia. Insulin deficiency also increases lipolysis through disinhibition of hormone-sensitive lipase. This causes lipolysis and generation of free fatty acids, which are then converted into ketones. Hyperglycemia causes hyperosmolality and osmotic diuresis, which leads to volume depletion and hypovolemia. Non-esterified fatty acids generated from lipolysis are converted into ketones in the liver. These ketones include acetoacetate and beta-hydroxybutyrate. These ketones are acidic, and bicarbonate is consumed as it buffers them. This causes metabolic acidosis with an elevated anion gap. Hyperosmolality due to hyperglycemia shifts potassium along with water from the intracellular to the extracellular space. The shifted potassium in the extracellular space is lost through urine. Insulin is absent in DKA and can therefore not promote intracellular potassium uptake. Thus, there is a total body potassium deficit, although serum potassium may be normal or paradoxically elevated. Question 7. What signs are expected to be elicited on examination of a patient with DKA? The patient may be ill-looking, have signs of dehydration such as dry skin, dry mucous membrane, decreased skin turgor. They may be hypotensive, tachycardic, tachypnic with Kussmaul breathing, and they may have altered mental status. Question 8. What homeostatic abnormalities are expected in DKA? Abnormalities expected in DKA include hyperglycemia, acidemia, hypovolemia, depleted total body sodium, potassium, and magnesium, and acute kidney injury from volume depletion. Question 9. What are the 3 key diagnostic lab features of DKA? The 3 key diagnostic lab features of DKA are acidemia, hyperglycemia, and ketonemia or significant ketonuria. Acidemia is a venous blood pH of less than 7.3 or bicarbonate of less than 15.0 millimoles per liter. Hyperglycemia is a blood glucose of more than 11 millimoles per liter or a non-diabetic patient. Ketonemia is defined as more than 3.0 millimoles per liter, and significant ketonuria is 2+ on urinalysis. Question 10. Interpret this patient's lab results. This patient has a hyperglycemia of 40 millimoles per liter. The degree of hyperglycemia does not correlate with severity. DKA can be seen with blood glucose ranging from as low as 11 millimoles per liter to even as high as 40 millimoles per liter, as in this case. There is also pseudohyponatremia of 126 milliequivalents per liter. The corrected sodium in this patient is 141 milliequivalents per liter, which is within the normal limit. The calculation for corrected sodium can be done using an online calculator. She also has a potassium of 4.3 milliequivalents per liter, which is within the lower end. This raises a concern for hypokalemia once treatment with insulin is started. She has a hypomagnesemia of 1.2 milliequivalents per liter, which is common in DKA. This can be replaced with the intravenous magnesium. The low bicarbonate of 10 millimoles per liter reflects metabolic acidosis since bicarbonate is consumed as a buffer. Hypochloremia of 88 milliequivalents per liter is a result of volume depletion resulting from vomiting and osmotic diuresis. The anion gap is elevated, and this is typical of DKA. Question 11. What are the differentials for anion gap metabolic acidosis? The mnemonic for causes of anion gap metabolic acidosis is CAT-MAD-PILARS. C for carbon monoxide or cyanide, A for alcohol, T for toluene, U for uremia, D for DKA, P for propylene glycol, paraldehyde or paracetamol, I for iron tablets or isoniazid, L for lactic acidosis, E for ethylene glycol, R for renal failure, and S for salicylates, sepsis, or starvation. Question 12. What are the differentials for ketoacidosis? The differentials for ketoacidosis include diabetic ketoacidosis, alcoholic ketoacidosis, and starvation ketoacidosis. Question 13. What are the differentials for a patient with hyperglycemia and hypovolemia? The differentials for a patient with hyperglycemia and hypovolemia include DKA, sepsis, and acute pancreatitis. Question 14. What are the 3 prongs of managing DKA? The 3 prongs of managing DKA include potassium, intravenous fluid, and insulin. The management of DKA varies according to specific hospital policies. What are the general management steps of DKA? While the management of DKA varies according to specific hospital policies, the general management steps of DKA include checking blood glucose, ketone bodies, and potassium. Intravenous fluid is administered to replace fluid loss along with an insulin drip. Blood glucose and ketone bodies are then rechecked. If glucose is normal and ketones are high, continue insulin and now give dextrose with potassium. Once glucose is normal and ketones are normal, stop the insulin infusion and give potassium as needed. Potassium may be given before insulin, as insulin shifts potassium into cells and the large volumes of intravenous fluid increase urine output and potassium wasting. Intravenous fluid is given in large volumes, and this can be either normal saline or Ringer's lactate. If glucose lowers but the anion gap does not close, switch to a D5 containing solution. Insulin is given intravenously until the anion gap closes. Once the anion gap is closed, switch to subcutaneous insulin and start food. Remember, in DKA the body thinks it is starving and activates starvation ketosis, which creates the anion gap. Question 16. What are the general fluid management guidelines for DKA? The general fluid management guidelines for DKA is 1 to 3 liters of normal saline in the first hour, 1 liter in the second hour, and 1 liter in the next 4 hours. Question 17. What is the general insulin guideline for managing DKA? The general insulin guideline for managing DKA is intravenous insulin at 0.1 units per kilogram per hour. Question 18. What is the role of insulin in DKA? The role of insulin in DKA is to drive glucose into the cells and to inhibit hormone-sensitive lipase and stop ketone body production. Question 19. What is the hourly goal of insulin drop in DKA? The hourly goal of insulin drop in DKA is 4.4 to 5.5 millimoles per liter per hour. The insulin drip is started at 0.1 units per kilograms per hour. When glucose levels reach 13.9 to 16.6 millimoles per liter or drops at a rate of more than 5.5 millimoles per liter per hour, add D5 to the fluids. Once pH is more than 7.3, bicarbonate is more than 16 millimoles per liter, anion gap is normal and the patient is eating, subcutaneous insulin is started, and the insulin drip is discontinued after 1 hour. Question 20. When is insulin infusion stopped in a patient in DKA? Insulin infusion is stopped once ketones return to normal and not when glucose levels are normal. Ketone bodies will still be produced even when glucose levels are normal. Insulin is needed for its inhibitory effects on hormone-sensitive lipase. Question 21. What are the general guidelines for replacing potassium in DKA? In general, if serum potassium is more than 4.5, no potassium replacement is required. If serum potassium is 3.5 to 5.5, 40 millimoles of potassium chloride can be added per liter of intravenous fluid. If the potassium is less than 3.5, the insulin infusion is stopped and a senior can be consulted for higher doses of potassium. Question 22. What is the best measure of severity in DKA? The best measure of severity in DKA is serum bicarbonate or the anion gap, not blood glucose. If serum bicarbonate is very low, which means there is a very high anion gap, the patient is at risk of death. Question 23. Why is bicarbonate only reserved for severe acidemia, that is a pH of less than 6.9 in DKA? Bicarbonate is only reserved for severe acidemia since it is converted into carbon dioxide, which causes widespread cerebral vasodilation and cerebral edema. Bicarbonate also increases the work of breathing and can exacerbate the acidosis. Question 24. What is the most feared complication of DKA? The most feared complication of DKA is cerebral edema. Edema can especially occur in children when fluids are given too rapidly. That's it for today. If this was helpful, you can find illustrations, questions, and more on this topic at hyperexcision.com. See you next time.